Good afternoon, everyone. I'm Srikriti Baskoda. I'm currently the ASC e-Journal Committee Vice Chair. Welcome to yet another month of ASC e-Journal live presentation. Today we have Dr. Nicole Anderson-Dio. She's currently a PZY3 resident at Geisinger Medical Center, Danville, Pennsylvania. She's going to be the upcoming cytopathology fellow also at the Geisinger Medical Center, and she will come back to complete her anatomic pathology residency following her fellowship. She's also currently a junior member of ASC e-Journal Committee. With that, I'm going to hand over to Nicole, but I just have a quick note to make. If you want to ask any questions throughout the presentation, there is a chat box or a question tab through which you can send us your questions, and I will moderate the questions towards the end of the session. Nicole, this is all yours.
Thank you, Dr. Baskoda. So I will be presenting liquid-based rapid on-site evaluation of endobronchial ultrasound cytologies. This was published in the Journal of the American Society of Cytopathology in the November to December 2022 issue. We only have one conflict of interest to disclose, which is that Dr. Andrew Fischer, who is an author, is an inventor of salient cell block technology, and he does receive royalties for that. And so I would now like to introduce our first author, Dr. Shi Bai. Dr. Bai is a current fellow of GUGYN at Massachusetts General Hospital. She completed her APCP residency training, followed by a cytopathology fellowship, both at the University of Massachusetts Chan Medical School. And we also have joining us the author, Dr. Fischer, as I already mentioned. He is the director of cytopathology at Massachusetts Memorial Medical Center. So thank you both for joining us, Dr. Bai and Dr. Fischer. Our objectives today are to understand the value of rapid on-site evaluation, understand the challenges of ROSE as they are identified by the authors in conjunction with clinicians at their institution, understand the concept of liquid-based ROSE and the rapid staining processes developed by the authors, in addition to some of the steps of the validation processes, which we will discuss. Finally, we will be able to describe the advantages and limitations of liquid-based ROSE compared to conventional smear-based ROSE. So we know that endobronchial ultrasound-guided transbronchial needle aspiration is emerging as the safest and most efficient way for diagnosis and staging of lung cancer, and that the overall goal of ROSE is to ensure a patient only needs one minimally invasive procedure for complete diagnostic evaluation. The authors worked directly with clinicians to identify the indications of ROSE, as this was an essential step to understanding the value of the ROSE procedure. The 5 indications for ROSE identified by the authors were to know if the lesion is reached and if it will yield diagnostic material, to decide whether ancillary studies will be needed, to ensure if the sample has been collected for all of the indicated ancillary studies, and sometimes to know if the lesion is definitively benign or malignant. Cytotechnologists are able to provide assessment for these first 4 indications, which the paper defines as accurate adequacy. The 5th indication, an accurate actionable diagnosis, is provided by the cytopathologist, and this metric is defined in the paper as accurate diagnosis. While we know how important ROSE can be, we also know that there can be significant challenges to performing the procedure. One of the challenges of ROSE that the authors pointed out is that ROSE is time-consuming. In the American Society of Cytopathology's 2019 survey on the use of ROSE, 86% of 261 cytotechnologists and 53.9% of 255 cytopathologists surveyed reported a typical ROSE procedure requires more than 30 minutes, while 40.3% of cytotechnologists and 13.5% of cytopathologists surveyed reported a typical ROSE procedure requires more than 45 minutes of time. Some of the other challenges of ROSE described by the authors is that ROSE may require 2 lab personnel per procedure, and reimbursement for ROSE is typically below the cost for a cytopathologist. Another challenge noted by the authors is that traditional smear-based ROSE can generate more readings than clinically actionable. And this is due to the material needing to be either immediately made into a smear or transferred to a stable rinse solution. It is technically challenging to produce a well-preserved and well-stained smear. And finally, the material in which ancillary tests need to be performed is not evaluated in the actual ROSE procedure. To address some of the challenges of ROSE, the authors developed and validated a liquid-based approach to ROSE. To generally summarize this liquid-based approach, all material from one site is collected into a cytology rid solution, and then a controlled amount of material is removed in the pathology lab and made into a single monolayer preparation that is then interpreted intraoperatively, similar to reading and reporting the results of a frozen section. So I now have a question for one of the authors, Dr. Bai. What made you realize the need for a different ROSE method at your institution, or was there something about your department operation that prompted the need for a change?
Dr. Bai, you're muted, I guess.
I'm muted.
Oh, sorry. I think we are facing same challenging as you just mentioned. So our UMass had multiple campuses. The cytopathologists, the cytotechnologists, and the fellows are usually not physically at the sites where the EBUS procedure was performed. And usually the procedure itself is time consuming, and we do require 2 people to keep up the procedure. As we all know, sometimes the collection of the sample can be faster than the ability to prepare, to stain, and to read. And also there's a technical challenging in the sense that, you know, we all know the smear can sometimes it's hard to prepare it's a quality because of these blood air dry artifact. And also this is also important that when we evaluate the smear rows, the ancillary tests that need to be done in the cell blocks are not evaluated during these rows, during the smear rows. So all those factors, a challenging trigger to think about if there's an alternative way to achieve the value of current conventional smear-based rows, but also can overcome some of these challenges. Yeah.
Thanks, Dr. Bai. I'm now going to briefly describe the methods used during the EBUS procedure. The ION, a robotic-assisted bronchoscopy platform, was used in all cases. EBUS, or transbronchial needle aspiration, was performed with a 21 or 23 gauge flexion needle. Brushings were performed with the Liberty cytology brush, and brushes were rinsed in saline before additional same-site collection was performed. Material was rinsed in 10 milliliter vials of CytoRich Red, which is a fixative that lyses and solubilizes red blood cells and serum proteins. We'll talk a little bit more about CytoRich Red in a little bit. The clinicians used visual inspection of the vial under clinical judgment to determine if the specimen is adequate. The study defined that the proceduralist would perform a minimum of 3 needle passes in 2 brushing samples, or a maximum of 8 needle passes and 4 brushing samples. When the clinician had the impression that the sample would be informative, it would be sent to the pathology lab. In the pathology lab, the vials would be visually inspected for turbidity or the presence of fine particles. If turbid or fine particles are visible, 1 milliliter or approximately 10% of the sample would be removed by pipette. Alternatively, if the sample appeared clear or had few particles, 2 milliliters would be removed by pipette. The pipetted sample would be added to a preserved site vial after 1 to 2 milliliters of preserved site fluid had been removed. A thin prep slide would then be immediately prepared and then stained with a rapid H&E procedure using disposable jars. The total H&E staining time was measured to be less than 3 minutes. In the pathology lab, a cytotechnologist could assess only adequacy, while a cytopathologist or supervised cytopathology fellow could provide both adequacy and diagnosis. The metrics recorded included adequacy and diagnosis, time between receipt of the sample, pathology callback time to the proceduralist, the amount of specimen removed from the specimen vial, and whether the thin prep for the liquid rose ran dilute. Accurate adequacy was defined by if the cytotechnologist or cytopathologist could correctly identify whether the clinician had acquired the sample, whether ancillary testing was needed, and if the sample was suitable for all indicated ancillary tests. In the study, it was important to note that not all samples called adequate were used for ancillary testing. We will discuss this further in the results section. For the positive for malignancy cases, an adequate reading was deemed accurate when the sample was sufficient for all subsequent necessary ancillary testing, including greater than 200 tumor cells and greater than 10% tumor cells per cell block section for cases potentially requiring next-generation sequencing. The definition of accurate diagnosis at the time of Rose was based on comparison to the final diagnosis. After the Rose procedure was completed, cases called inadequate were generally prepared with a second thin prep slide with the lab standard Papa-Nicolau stain. If the thin prep did not run dilute, the residual material was prepared into a salient cell block. In the cases of samples called adequate, these samples were generally entirely prepared into a salient cell block. I'm now going to discuss validation protocols performed. This lab needed a rapid stain that would ultimately be compatible with telecytology, so there was a trial and error period of using different rapid staining techniques. The lab attempted to use Diff-Quick Blue to make monolayer preparations from residual material in thin prep vials following diagnosis, but the stain had variability and generally lacked cytoplasmic to nuclear contour. They also attempted to use a rapid two-step Papa-Nicolau stain, which was slow. Choosing a stain which was both rapid and showed appropriate cellular detail was very important to the success of this method. I'm now going to talk about the rapid H&E validation, which was ultimately used in the study. First, it's worth noting that the eosin was diluted to 10% of its original strength. For the validation, 20 thin prep vials with residual material from FNA samples were prepared into a monolayer slide stained with H&E. All cases demonstrated comparable chromatin preservation and display with roughly stoichiometric staining of chromatin compared to DNA contents, transparency groups, and cellularity. The diagnoses on the 20 cases by H&E matched the blinded diagnosis of the original Papa-Nicolau stain slide from the original cases in all 20 cases. Next, I'm going to describe the 10 to 20% aliquot validation. The material chosen for validation came from leftover material in the thin prep vials after the cases had been finalized. The cases chosen were ones that had been diagnosed as either negative or positive. As previously described, based on turbidity of the sample, 10 to 20% of the remaining sample was removed for creating a monolayer preparation. 20 samples were assessed, and the diagnosis of the 10 to 20% sample was compared to the final diagnoses for the case. It was predetermined that if the 10 to 20% sample was not diagnosable or was falsely negative, then the 10 to 20% sampling technique would be deemed not valid. Scoring and diagnosis were done blindly, and only the specimen source given. The results showed 100% concordance between 10% and 20% sampling methods in the final diagnosis. Now we will discuss the results. The first total 52 liquid-based Rose readings from 30 patients used in the EBUS TBNA are presented in the study. Of all 52 readings, 28 readings, or 53.8%, were interpreted as adequate in Rose with final assessment as adequate sample. 17 cases, or 32.7%, were interpreted as inadequate in Rose with final assessment as inadequate sample. There were no false positive adequacy readings. Readings interpreted as adequate, but not actually adequate for ancillary testing. There were 7 false negative adequacy readings, or 13.5%, interpreted as inadequate in Rose, in which the final assessment was actually adequate for a complete diagnosis. 4 of the 7 readings from 2 patients were benign inflammatory necrotizing processes on final diagnosis. 3 cases were positive for malignant cells on final diagnosis. Molecular testing was requested on only 2 samples, and both had sufficient quantity and quality of DNA and cell blocks for complete next-generation sequencing using the ion torrent system. Depicted here is the raw data for adequacy and preliminary diagnosis by liquid-based rows in correlation with the final sign-out. We can see that there were 30 patients in the study and 52 readings. The specimen types included mostly fine needle aspirations of nodules or brushings of nodules. There were 7 lymph node fine needle aspirations. 4 of the 7 lymph nodes were inadequate at the time of rows, but the final adequacy was adequate. The liquid-based rows evaluators included a mix of cytopathologists, cytopathology fellows, and cytotechnologists. Here we have some example images of cases from the study that were positive for carcinoma. All the slides were stained with hematoxylin and eosin. Image A shows 3-dimensional tumor cells with waxy cytoplasm and cellular bridges, a finding of squamous cell carcinoma. The preparation was made using a 10% aliquot of sample. Image B is the same case with abundant tumor cells in the cell block. Image C shows 2-dimensional tumor cells with intranuclear cytoplasmic inclusions, a finding consistent with adenocarcinoma. Image D shows a cell cluster with nuclear molding, highly variable amounts of nuclear material, abnormal chromatin, and single-cell necrosis. This was diagnosed as small cell carcinoma. Of the 23 readings provided with a diagnosis by cytopathologist or cytopathology fellow, 13, or 56.5%, were interpreted as positive for malignant cells. 2 cases, or 8.7%, were interpreted as negative for malignant cells. 6 cases, or 26%, were interpreted as non-diagnostic, and 2 cases, 8.7%, were interpreted as atypical. For definitive benign and definitive malignant cases, the sensitivity and specificity is 100%. If atypical is a false negative, sensitivity drops to 93%, and if atypical is a false positive, specificity drops to 80%. Figure 2 highlights a few examples of rows preliminarily interpreted as atypical or non-diagnostic. Image A is an example of one of the 2 row samples preliminarily called atypical. In this example, there is subtle hypochromasia of the malignant cell group on the left with benign bronchial cells on the right. This was ultimately diagnosed as predominantly lipidic pattern bronchial alveolar adenocarcinoma. Image C is an example of the second row sample, preliminarily called atypical. In image C, there is reserved cell hyperplasia from a benign necroinflammatory process. This was ultimately interpreted as benign. In image B, this material was interpreted as non-diagnostic and was ultimately a benign necroinflammatory process also. Finally, in image D, this is a nice example of fungal hyphae, which was called adequate in preliminary rows and negative for malignancy on final diagnosis. Now to discuss the results of time impact of liquid-based rows. Delivery of the sample from the operating room to pathology lab took an average of 3 minutes. Time from the receipt of the sample in the lab to a reported rows ranged from 6 to 22 minutes, with a mean time of 13 minutes, median time of 12.5 minutes, and a mode of 12.5 minutes. Moving on now to the discussion. A highlight of note is that this is the first study using a liquid-based cytology method for rows procedure in which a controlled and measured amount of material was prepared into a thin prep slide, stained with a rapid H&E, and interpreted. Also, to reiterate, the goal of developing liquid-based rows was to achieve the values of smear-based rows, to overcome some of the limitations of smear-based rows, and to facilitate estimation of the adequacy at the time of rows. Before we get into the further details of the potential time-saving aspects of liquid-based rows, I wanted to discuss the goal of facilitating estimation of adequacy at the time of rows. The paper cites the study Rapid On-Site Cytological Evaluation during Endobronchial Ultrasound-Guided Transbronchial Needle Aspiration for Nodal Staging in Patients with Lung Cancer, published in the Annals of Thoracic Surgery in 2013 by Dr. Takehiro Nakajima, which found the concordance rate for staging between rows and final pathologic diagnosis was 94.3% using conventional smear-based rows. In this study, when considering cases as benign or malignant, if atypical was considered a false negative, the sensitivity of liquid-based rows is 93%. It seems reasonable to consider liquid-based rows comparable to smear-based rows in terms of sensitivity and specificity. So my next question for the authors is, do you think that liquid-based rows at your institution has attained the goal of facilitating an accurate estimation of adequacy at the time of roast comparable to smear-based rows?
Dr. Bai, you're muted again.
Okay, so I have to control myself. Sorry again. So the short answer is yes. I think we're now achieved the goal of accurate estimation of adequacy. So back to our all 52 readings. There are 28 reads were read at the rows as adequate, and all of them concordant as a final interpretation. There are previous studies has shown the accurate estimation of adequacy in lung and mesodymal FNA was about 95% using the smear-based rows. So I think we're comparable, and I think we're pretty good at estimating the adequacy. Yeah.
Thank you. In the discussion, it is mentioned that it is safer to err on the side of calling a benign process inadequate. Here we can review the situations in which the adequacy of malignant cases were underestimated. Liquid-based rows performed well determining the 4 components of adequacy, with some tendency to underestimate adequacy, but no overestimation of adequacy. In 3 readings from 3 patients with malignancy, which was 3 of 26 or 12% of patients with malignancy in the study, adequacy was underestimated. One case, which was mentioned as reading 5, patient 3, read by a pathologist, proved more cellular with immunohistochemistry in the cell block than expected. The other 2, reading 37, patient 21, and reading 38, patient 22, were read by cytotechnologists, both with final diagnoses of squamous cell carcinoma. Upon review, both were determined to actually have sufficient material based on the liquid row slide, consisting of mostly individual squamous cells with abundant necrosis. All cases eventually had greater than 200 cells and greater than 10% tumor cells per cell block section. The paper describes how most laboratories, and including your laboratory, use cell blocks for ancillary testing. Can you describe, question for the authors, how the liquid-based method with prep slide creation errs on the side of underestimation of tumor cellularity, and how this could be beneficial?
I think majority of our cases, we have a good concordance with adequacy. We at the site call adequate and inadequate. But as I just mentioned, we do have 7 cases where we underestimate adequacy. I think it's safe in the error that we tend to underestimate, especially in those benign inflammatory process, because we do want to make sure the sample is the lesion is well sampled to completely exclude a malignant process. So in that situation, the reader tend to be on conservative side, make sure we got enough sample. But there are also 3 malignant cases where, when we look back, we reviewed thin prep. The squamous cell carcinoma is predominantly individual located with abundant necrotic background, so make the reading a little bit challenging. Yeah.
Thank you.
Yeah, could you expand a little?
Absolutely. Sure.
Just basically, the whole concept was that we were taking a controlled amount from the vial and then hopefully loading a thin prep in such a way that it would run dilute, meaning that the entire sample would be deposited on the slide. And if you're removing like 10% of the sample, you'd see roughly what percentage of the cells you have. So we expected, a certain level of correspondence in between the number of cells that we're actually seeing on the slide and then the number that we would get in our cell blocks from that. And we just started out by being a little bit cautious of it, and I think we're doing a follow-up study now to really pin down the relationship between the number of cells you see on that thin prep slide and the number that you're going to see in the thin prep section. So I think that we're pretty accurate about that,
Gotcha.
estimating the adequacy.
Thank you. I'm now going to spend some time describing how this laboratory uses CytoRich Red as the collection media for all FNAs and non-gynecologic brushing, since this may differ from practices in other laboratories. So since 2000, the performing laboratory has used CytoRich Red as the collection media for all FNAs and non-gynecologic brushings. Immunohistochemistry and molecular procedures have all been validated on this platform. To be able to use thin prep processing on routine samples, the lab centrifuges material out of CytoRich Red and resuspends the sample in preserve site. Once resuspended, most routine FNA and brushing samples have a thin prep prepared and a cell block made if a sample did not dilute or if a sample has 5 visible particles. So my question for the authors is now, why did you choose to use CytoRich Red instead of Cytolite?
So we've always used CytoRich Red, and since all of our processes are validated on that's what we, of course, wanted to continue to use, so we wouldn't have to validate more. But there's a really good reason for using CytoRich Red, and it is that it lyses all of the red blood cells, which is a pretty easy thing to do. A dilute alcohol solution would also do that. Cytolite also lyses all the red blood cells, but the advantage of CytoRich Red is that all of those lysed red blood cells and all of the serum proteins in CytoRich Red do not precipitate out. Whereas in Cytolite, you can lyse all of the red blood cells, but very quickly, all of the proteins that are lysed and released from those cells precipitates out. So in fact, you can do the experiment. It's a kind of a fun one to do. If you take like 100 microliters of blood and put it into Cytolite, you lyse all of the red cells, but very quickly a precipitate will form, and the volume of the precipitate will measure about 100 microliters. So you haven't actually accomplished getting rid of the debris that you don't want to see. So that was the whole concept behind Celliant. I know we've got a conflict of interest, but the whole concept is that we really want just the cells of interest, and we want to make sure that we can recover those cells, which is what Celliant was designed to do quantitatively. So another major reason that I think if labs want to adopt this liquid-based rose, I think you should consider using CytoRich Red, because since it lyses all of the material, if you have a sample that's diluted with a little bit of blood, you can see how much actual sample you got. The blood cells will go away, it'll be crystal clear, and then you can see the actual particles that are left over. That's going to be the diagnostic material. And so we got the clinicians really kind of engaged in the process of rose, which is an interesting thing in itself, because if you think of it, cytopathologists who do ultrasound guided FNAs, they get pretty quickly feedback over their technique. They'll see, I guess I don't really need that much suction to get a good sample, because you'll see that the smears that you make that we ourselves will be reading, we can see that there's lots of material on that smear, for example, or conversely, we can know that some technique doesn't work very well. The clinicians never get that feedback in rose. They kind of do a little bit, but because they're getting an answer 5 minutes later or whatever after their pass. But now they're really directly engaged with that process. We have shown them how to look in the container and look, is it clear or are there particles? And they can pretty quickly get a sense, okay, this has got some particles in it, or this one doesn't, and they can learn, and they have learned to adapt their technique. They use a slow pull, method for minimal amount of suction to get a minimal amount of blood. And so that's been very helpful for them. The use of CytoRich Red has been really helpful, because they don't even send a sample until they think that it looks like it's about right. In practice, they typically do, if you're in there in the OR, they're giving you a pass about every 2 or 3 minutes, which is faster than you can actually process them. So you end up getting passes when you don't really need them. And by the time, they're not going to probably stop doing passes until they've done 3 anyway. So we thought it really doesn't pay to actually look at those first few passes. A third pass might kind of ruin the other passes if it had a lot too much necrotic debris or something like that. So all of this is to say that the use of CytoRich Red gave them the feedback about when a sample would be adequate. And so that's why we like it.
Thank you for explaining. Yeah, I think it's really great how much you worked with your proceduralist to kind of get feedback about this whole process. That's very interesting. So now I'm going to discuss that the monolayer rose procedure was adopted to allow it to be used on CytoRich Red needle rinses, making the sample treatment identical to all existing protocols. An off-label use of the T2000 thin prep processor by Hologic was developed by adding 1 to 2 milliliters of CytoRich Red to the preserved site vial and then immediately running the thin prep rather than taking the time to centrifuge in keeping the sample for 15 minutes per the thin prep T2000 protocol. The authors noted that this saves about 20 minutes of time. I'd now like to discuss some of the advantages of liquid-based rows over smear-based rows, which includes time saving to the pathology lab. The time spent ranged from 9 to 22 minutes with a mean of 13 minutes. Liquid-based rows requires only 1 individual for the procedure. There's minimal training required to perform liquid-based rows. And finally, liquid-based rows creates a uniform presentation of cells free from blood and air-drying artifact. And also the cells are composed to a defined area of the slide. I have another question for the authors, which is, are there any aspects that you think save the most time or were especially helpful for your institution?
So I think overall we benefit all the advantages you just mentioned, but if you have to choose the most aspect that we benefit from this change is that we are cutting the personnel from 2 to 1 and also save the whole procedure to 15 minutes. So it's a really huge benefit for us because we are short of staff and now we're only sending 1 person doing procedure and with a limited time. So we can have other people doing other routine work. So which is a very good aspect of this procedure.
Can I just add that I think it's actually easier to teach something to do a thin prep than it is to make a good smear and to triage. You get this little tiny dot of stuff that you're trying to divide between the needle rinse and the smear, and then trying to make a smear without crushing, or that's actually really technically difficult. And I think you really can't rely on just anybody to do that if you're going to be doing conventional rows. But the liquid-based rows is pretty easy to just teach somebody. If it's cloudy, take 2 ml or 1 ml. If it's not cloudy, take 2 mLs. Push the button on the machine, and you get the prep.
I have a follow-up question since we're talking about the possible advantages of liquid-based rows. We noticed that your lab started using liquid-based rows for the diagnosis of lung cancers in patients who then have an immediate lung resection for cancer based on the rose diagnosis. How is that going?
So it sounds a little bit scary, I think, at first when you think of it, but I mean, this whole liquid-based rows, first you have to obviously validate what you're doing before you can even offer this, right? And that's what we went through, these steps of validating first the actual stain that we were going to be using, and then validating or basically verifying the 10 to 20% aliquot idea. Mm-hmm. So with that then sort of validated, now we're able to offer the test. Based on our years of experience with conventional rows, and then with these next 50 cases, now we've done at least 100 or more with the liquid-based rows. We realize that the pitfall is not a false positive, right? We don't have false positives. Watch out for the reserve cell hyperplasia that can have a little bit of atypia, especially in those upper lymph nodes, like a station 7 lymph node. I think they seem to get a little bit more dysplastic-like changes in that bronchial epithelium. That can be a little bit of a pitfall. There's a few pitfalls to be aware of, but by and large, the problem is not a false positive, it's a false negative. And going back to one of your earlier questions, Nicole, I think the problem that we have with false negatives has to do with the biopsy needles. They simply don't get a good sample of benign lesions, generally speaking. So they're really, there's a tremendous need for industry or some sort of partnership to get better biopsy needles for these benign lesions. I think we would do a much better job. We're deliberately not trying to take big chunks of material, which are best suited, we think, for the cell block. So those would be where you might find some of the benign material. I think that explains why some of the ones that were not adequate based on the small aliquot that we were taking of the finest debris, finest material in the sample. Those finest materials are not likely to be the big cross-linked chunks of tissue that you might get from a benign lesion. So anyway, there's a problem with false negatives. And if you just take the idea that you're going to just be not giving a diagnosis until you're absolutely sure, and when you look at your results over years of doing conventional rows or liquid-based rows, you realize that that's still, far more than 50% of the time. So the glass is a little bit more half full than it is half empty. And the clinicians still need to address what this lesion is. And the only way to do it non-invasively is with cytology. And if they don't come up with an answer by cytology, if it's a non-diagnostic cytologic thing, they pretty much have already decided with the patients that they're going to do a wedge resection at least. So that's kind of the backup that you should feel when you're going into, anybody is going into these RODAT, we'll call RODAT procedures. It's rapid, one anesthesia, diagnosis, and treat. Kind of a funny acronym, but that's the one we use here. Are there other, I'd be curious if there are other labs doing RODATs, because I haven't heard of people reporting that, but at any rate, moving towards that has been an interesting thing. We now have cross-trained all of the staff to do it. It involves basically just a technical person to make the prep. They can deliver it then to the pathologists who might be over at this other outside clinic, which is not our usual clinic. This is why we kind of had to come up with something. They can deliver the slide to them, and everybody's cross-trained to do these now. And so we've done about 20 so far. We've had 16 that have been outright positive, 16 out of 20. One was considered suspicious, and that ended up being a well-differentiated mucinous lipidic pattern, BAC. I think everybody can appreciate that that's a really bland tumor, right? It looks like kind of normal bronchial epithelium. It's a very flat two-dimensional sheet. There's no nuclear variation, no hyperchromasia. You might see an intranuclear inclusion, which is a good tip-off for cancer, but you don't always see it. And that's a particularly difficult diagnosis. The diagnostic trait that we've learned to kind of recognize is that, unlike bronchial epithelium, where you'll see mixtures of some goblet cells and some ciliated cells, it's very monotonous. It's a pure population of mucin producing cells. So it otherwise looks just like bronchial epithelium. Anyway, that was a suspicious, because it was suspicious and they had consented the patient, they also resected that one. So 17 resections for cancer, all non-small cell carcinomas. We had one negative. I called it negative because it was dense chronic inflammation. They kept sampling and sampling and sampling. There's a potential pitfall because some cancers will have a lot of chronic inflammation around them, but they were sampling widely. And that was, and in fact, that was a case that I ended up going into the OR because I kind of wanted to know what was going on. I wanted to see things. Follow-up at 6 months, they did not do a resection because we called it, we said we have an explanation for a lesion and it looks benign. And follow-up after 6 months has been showing us a slight decrease in the size of that lesion. We worked it up for lymphoma as well. We had one non-diagnostic one where they were clearly in the lesion. We clearly didn't see lesional material. We just didn't see fibrosis, didn't see anything. And I called it non-diagnostic and they said, well, we've consented the patient to take this out. They took it out and it was a really desmoplastic adenocarcinoma. And that's, again, that's a problem with the biopsy needle. So I think improvements in the biopsy needle will make that an easier thing to deal with in the future. And finally, there was one other one that we called negative, but they had the consent of the patient to basically do either a wedge or the lobectomy if it was positive. Since we called it negative, they did only the wedge, and the wedge showed that it was a benign lesion. I think that was an organizing pneumonia. So we've basically been very helpful to a lot of patients. We cut the wait time from the time of a diagnosis, the first appearance of a nodule, to resection went from 123 days. There's lots and lots of visits, lots of x-rays. You know, they wait for the biopsy results, they do this, they schedule another meeting with anesthesia. It went from 123 down to 76, which still sounds kind of long, but it's still a huge improvement, and patients have been really quite grateful for this service here. So we've had a good result with it. I think just approach it very carefully, use your expertise that you've gained. I wouldn't rush to liquid rose on this until you've gotten some experience with liquid rose. And I think if you do liquid rose, you're going to want to change to CytoRich Red. Otherwise, you won't really know how much to remove. You also won't be able to know, won't be able to see very much on the slide because there's so much debris. I don't know if you've seen this type of thing, but if you have a bloody FNA, prepared with Cytolite, you're going to have mostly debris on the slide. You're not going to have a lot of cells. We wanted to have lots of cells. We wanted to represent the whole 10% or 20% of the sample. If I can keep going for just a second.
Sure.
The next generation, I think, for the RODAT procedure, they've been doing the surgery mostly on patients who are ostensibly, stage 1, not likely to have mediastinal lymph node involvement, or T up to T2 lesions, I guess, right? Still stage 1, but they want to expand this rapid diagnosis and treatment in one anesthesia. They want to expand it to patients who have either larger tumors or equivocal findings on PET or CT, suggesting possible lymph node involvement. So for those procedures, this is a little bit getting tricky, and I'm a little bit concerned about it. We're doing a little study to figure out if this is how feasible this is, but the idea is that we have to be sure that there's not cancer when they do a rose on a mediastinal node. So that's another reason you really have to have a lot of material on that. You want to have as much of that sample as you can, maybe 2 thin preps, but you certainly don't want to be using Cytolite for that, I don't think, because you're going to have mostly debris and you won't be able to make enough thin preps to see much of the sample. So that's an interesting challenge for us.
Well, thank you very much for expanding the discussion, Dr. Fischer. And if anyone else listening, if they have experience for RONAC or at their institution and want to chime in or sort of just expand on this whole discussion, feel free to. I am nearing the end of the presentation, so we do have time if anyone is thinking about kind of what we just talked about. Please interrupt me. Otherwise, I'll finish. So now I'm just going to discuss a few potential drawbacks of liquid-based rose, as discussed in the paper. One of which is the cost-benefit balance, which may be an issue for some institutions. In general, the supply costs of the laboratory are less favorable. Liquid-based preparations require purchase of thin prep materials, including processor and disposable filters, which is an additional cost. Also, only one reading per site was needed, which means that there is only one 88172 CPT code for liquid-based rose versus the possibility to bill multiple 88177 CPT codes in a conventional rose procedure. And then finally, we're going to discuss the limitations of the study. First, the anesthesia time of smear-based rose EBUS procedure was not compared with that of liquid-based rose EBUS. The discussion mentions that proceduralist impression at this institution was that the time for liquid-based rose was not problematic. Second, flow cytometry was not indicated for any patients. So this is kind of admitted that there would be a required adaptation of the workflow or protocol if flow cytometry was needed for some of these patients. And with that, that's all I prepared for the discussion of this paper. Does anyone have any questions or want to continue the discussion about anything?
Thank you so much, Nicole. That was wonderful presentation. And thank you, Dr. Fischer and Dr. Bai, for this wonderfully written article. I learned a lot, and I have a question from myself, and then there is one question in the chat as well. So I was wondering if you are using CytoRich Red regularly in other kind of specimens as well.
Maybe I can answer that too. So again, I have a conflict of interest with Celient, but Celient, has pores, kind of like a thin prep machine, and once the pores are saturated, it won't load any more material. They had a clever use of like they redisperse everything so that they can add a little bit more, but you really can't add very much more after it's gotten saturated. So in fact, I know people have not particularly thought that the cell blocks are very cellular with Celient. The reason they're not cellular, I'll state it clear as I can do it, it's because Cytolite causes a lot of debris to be precipitated. And it's a kind of a, it's not, I don't blame anyone for this. I mean, it's partly a consequence of the way Hologic and the FDA, or the way the FDA is set up, basically. They have to give the protocols that they used when they developed Celient, and they worked with Cytolite. It's their product. It makes sense. And then at that point, the FDA gives them, permission to market it in a certain way, and they have to market it basically as using Cytolite. So it's unfortunate. And I think just in general, what we're doing with the liquid-based rose, we're adapting protocols, we're adopting technologies that are out there because they don't quite work perfectly for what we need them to do. And Celient is, I think, an unfortunate example of that, where if people could validate the use of CytoRich Red, they'll see that it gives you a much better sample. IHC is not an issue. So it's been quite a learning curve for me. The Hologic reps, the field reps are wonderful people, but they can't tell you, they're not allowed to by the FDA regulations. So it brings up a bigger issue about, like, can the ASE be involved with, facilitating people to validate things? Otherwise, every single lab has to individually validate things. It's a little bit too complicated. So anyway, yeah, CytoRich Red is an excellent fixative, developed by John Maxim down in Florida. Super nice guy, very, very smart, clever to be able to find something that doesn't precipitate debris, but preserves antigens and gets rid of the red cells.
That is really interesting. I'm definitely going to take a further look to that. We have a comment as well as a question in the chat. Comment is, it's a great paper. Opinions of the application of this method to other types of procedures, including GI, for example. I think he's referring to liquid-based rose.
So Dr. Bai is going to be joining us. She was our fellow. This was her fellow project, by the way. She did a fabulous job on this liquid-based rose project, and is going to be coming back to us now after a second fellowship as an attending. But we have actually in this past year, when you haven't been with us, Dr. Bai, been using it for other procedures. So yeah, I think it's much easier, even at the universities. Where we have pathology there, we're able to use this more. I think it's more effective. I really like it. I think it's an easier way to do things. Yep.
Well, thank you, Dr. Fischer, for leading this project. Also, thank you, Nicole, for presenting this nicely, and thank you, Dr. Bascota, to holding this meeting. But it's good to know that it's also expanded to the GI for other service. Because as I just said, and when I finished my fellowship, we're using this mainly for EVIS procedure. So it's really good to know. Looking forward to those services as well.
All right, we have come to and I would like to thank the authors again for accepting our invitation and being here. And thank you, Nicole, for doing a wonderful job. Thank you, Joanne, for coordinating all this. We will see you all next month.
Thank you.